If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. Today, we're looking at the NICE updates published in December 2024, focusing on what is relevant in primary care only. In today's episode, we're covering two important clinical topics: tirzepatide for managing overweight and obesity, and antimicrobial prescribing for recurrent UTIs. But before we jump into the details, let's take a moment to highlight a game-changing development, the new NICE technology appraisal on tirzepatide. For many GPs, the surge in patient requests for Ozempic or semaglutide to manage obesity has been a challenging situation, especially as NICE does not recommend its use in primary care for this purpose. Could tirzepatide mark the end of the GP Ozempic nightmare? Right, let's find out. In the technology appraisal assessing tirzepatide for overweight and obesity, NICE has recommended it as an option for adults alongside diet and exercise only if they have an initial BMI of at least 35, reduced to 32.5 for people from Asian, Chinese, Middle Eastern, and Black African or African Caribbean ethnic backgrounds, and at least one weight-related comorbidity. Examples of comorbidities would be hypertension, dyslipidemia, obstructive sleep apnea, cardiovascular disease, prediabetes, and type 2 diabetes. If less than 5% of initial weight has been lost after 6 months on the highest tolerated dose, we will need to decide whether to continue treatment, taking into account the benefits and risks of treatment. We know that the availability of obesity treatments in primary care has been limited, with semaglutide for obesity currently recommended for use in secondary care only. However, this is an exciting development. NICE has now approved the use of tirzepatide in primary care for obesity too. Furthermore, indirect comparisons suggest that tirzepatide may be more effective than semaglutide in managing obesity. While the manufacturer initially proposed a BMI threshold of 30 with at least one weight-related comorbidity, NICE has a stricter criterion. For NICE, the acceptable threshold for NHS resource use is a BMI of at least 35 and at least one weight-related comorbidity. Let's talk a bit more about tirzepatide. Tirzepatide, marketed as Mounjaro, is available as pre-filled pen devices for subcutaneous injection, with doses ranging from 2.5 mg to 15 mg. It is a one-weekly injection indicated for type 2 diabetes and weight management. What type of drug is tirzepatide? Well, it is a dual GIP and GLP-1 receptor agonist. GIP stands for glucose-dependent insulinotropic polypeptide, and by activating the GIP receptor, tirzepatide enhances glucose-dependent insulin secretion from pancreatic beta cells, which improves glycemic control, and it also modulates lipid metabolism. GLP-1 stands for glucagon-like peptide 1, and by activating the GLP-1 receptors, tirzepatide also enhances insulin secretion, but it also inhibits glucagon release and it slows gastric emptying, leading to a more gradual absorption of glucose and reduced postprandial glucose spikes. Both GIP and GLP-1 pathways work synergistically to influence the central nervous system, suppressing appetite and promoting satiety, leading to weight loss. This combined mechanism offers unique benefits for managing both glycemic control and obesity. Is tirzepatide better than semaglutide? Tirzepatide is considered potentially better than semaglutide in certain contexts. For example, the dual pathway of tirzepatide allows multiple metabolic pathways, leading to superior outcomes. Clinical trials have demonstrated that tirzepatide leads to greater weight loss compared to semaglutide. Some studies reported reductions of up to 20% of body weight with tirzepatide versus around 15% with semaglutide. Tirzepatide has also shown superior glycemic control, achieving greater reductions in HbA1c levels compared to semaglutide in head-to-head studies. In addition, GIP receptor activation by tirzepatide may have additional benefits on lipid metabolism, such as reducing triglycerides and improving HDL cholesterol. These benefits are less pronounced with semaglutide. So, bearing this in mind, would we ever choose semaglutide over tirzepatide? Well, although both drugs share common side effects like nausea and vomiting, tolerability varies, and some patients may be intolerant to one drug but not the other, so this may have an effect on the choice of treatment too. Uncommon side effects of tirzepatide include gallbladder disorders and acute pancreatitis. We will discontinue it if there is persistent severe abdominal pain, and if pancreatitis is confirmed, we will not restart treatment. In summary, this is indeed a game changer. With tirzepatide now approved by NICE for use in primary care, we may finally have another clear, accessible option to treat the pressing issue of obesity and overweight in general practice. Let's now briefly touch on the updates on the prevention and management of recurrent UTIs. The changes include new referral recommendations, advice on estrogen use, new advice on methenamine hippurate, and choice of medication. Now let's have a look at the summary of the main points. We will refer to secondary care anyone with recurrent UTI of unknown cause, recurrent UTI and suspected cancer, recurrent upper UTI, recurrent lower UTI in anyone with a male genitourinary system, pregnant people, children and young people, and anyone who has had gender reassignment surgery that involved structural alteration of the urethra. We will consider vaginal estrogen as prophylaxis if the person is experiencing perimenopause or menopause, or they have already experienced menopause, and behavioral or personal hygiene measures alone are not effective. At the moment, this is an off-label use of vaginal estrogen. We will also check the NICE guideline on menopause, which includes advice on the use of vaginal estrogen if there's a history of breast cancer. We will review treatment with vaginal estrogens within 12 months or earlier if appropriate. But we will not offer systemic HRT specifically to reduce the risk of recurrent UTI. We will consider methenamine hippurate as an alternative to daily antibiotic prophylaxis for recurrent UTI in anyone with a female urinary system if they're not pregnant and any current UTI has been adequately treated and the recurrent UTI has not improved with behavioral and personal hygiene measures, vaginal estrogen, or single-dose antibiotic prophylaxis if appropriate. When discussing prophylaxis with methenamine hippurate, we will explain that over-the-counter sachets that make the urine more alkaline, such as sachets used to relieve UTI symptoms that contain potassium citrate or sodium citrate, should not be used while taking methenamine hippurate, because these can make it less effective. And we will also explain that medical help should be sought for acute UTI symptoms. We will review treatment with methenamine hippurate within 6 months and then every 12 months or earlier if appropriate. But what is methenamine hippurate? Methenamine hippurate is a prodrug of methenamine, which means it is inactive in its original form but becomes active after metabolism in the body. How does methenamine hippurate work? Methenamine is stable in neutral or alkaline conditions, but in acidic urine it is hydrolyzed into formaldehyde and ammonia. Formaldehyde is toxic to bacteria and has therefore antibacterial properties. So, for methenamine hippurate to be effective, it is necessary to maintain an acidic urine. This may be achieved naturally through dietary measures, for example cranberry juice or vitamin C, or with urinary acidifiers. Unlike antibiotics, methenamine hippurate does not target specific bacteria but acts broadly against a wide range, therefore reducing the risk of developing antibiotic resistance. Methenamine hippurate is used as a prophylactic agent rather than as a treatment for acute UTI. It is especially helpful in recurrent uncomplicated UTIs, for those who may want to avoid regular antibiotic prophylaxis. And finally, let's now look at the choice of prophylactic options. We can choose between antiseptic prophylaxis and antibiotic prophylaxis. For antiseptic prophylaxis, methenamine hippurate is recommended for adults, and it may be considered for children over the age of 6, but only with specialist advice. For antibiotic prophylaxis, as a first-line option, we will use stromisoprene or nitrofurantoin. As a second-line option, we will use amoxicillin or cefalexin. The choice of antibiotics should take into account recent culture results and adhere to local antimicrobial policies. So that is it, a review of the NICE updates relevant to primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.